I know this thing is on, and I know that you can hear me. Nursing and healthcare needs advocates and activism. So what are you waiting for? Let's do the damn thing. We've all heard stories of nurses or folks in healthcare that have been hit, kicked, spit on, sexually abused, assaulted, had names called, and for whatever reason in Canada we're so polite, we just don't talk about it. But it's problematic because if we don't have these conversations, we don't measure, we don't look at the stats, we can't actually fix a problem. So, as much as we're speaking about it, I think that, hospital organizations should speak about it too. Which brings me to a conversation, which recently I had been in an emergency department, and I was actually quite shocked to see that there were signs talking about workplace violence that occurs to nurses and healthcare providers, and that it is not okay. This is the first organization that I walked in that I've seen this, and I was quite taken aback. So, I think it's time, more than time, for us to have a conversation about workplace violence and what can actually be done. Because I'd say that most likely it's not really enough. Today, we're tackling that issue that touches almost every single person working on the front lines of healthcare: workplace violence. But we're not going to just talk about the problem. We are talking about an executive leader who is taking steps to actually doing something about it. Today, my guest is CEO Mike Heenan, the president and CEO of St. Joseph's Healthcare Hamilton. Mike brings over 2 decades of healthcare leadership to the table, including senior roles within the Ontario Ministry of Health and hospital systems across the province. Under his leadership, St. Joe's has launched a raw, unfiltered public campaign confronting the reality of violence against healthcare workers head on. And not only is he talking about it, he's here to tell us what he's going to do about it. Welcome, Mike, to the show. I'm so glad to have you here on the Gritty Nurse podcast. Finally, we've met and our paths have crossed many different times, and I'm so glad that you're finally going to come and speak to my listeners. Mike, you've held many different executive roles across across hospital systems and in the Ministry of Health, but every CEO takes a different path to the top seat. For folks that are listening today who might not know your background, who you are, what brought you to St. Joe's, and how has your career been shaped up until now?
Yeah, thanks. It's an absolute pleasure to be with you today and your listeners. I think you're playing an important role in advancing the profession of nursing, as well as clinical interactions, patient safety, patient experience, and worker safety. So thanks for having me today. I don't have a clinical background, so I'll just start with that.
Yeah.
I actually started in political communications in the Ministry of Health, I don't know, 25 years ago. And I had an opportunity to become a project manager here at St. Joseph's Healthcare Hamilton 25 years ago. And I've come full circle. So I worked for the CEO advancing strategic projects, I guess, in 2003. And I quickly learned that, you can contribute to healthcare in a variety of ways. And that can be through frontline clinical care. It can be as a clinical support service like portering and painting and infrastructure, supply management. But I had an MBA and learned that some business processes could be brought to the sector. And so I got some stretch opportunities here to do strategic planning and look at things like quality and performance and measurement, and really took off from there. And so my journey started here at St. Joseph's Healthcare Hamilton. I spent almost 7 years here. And then I got great advice, which was, because I wasn't a clinician, you should go out and do what you're doing twice. Do it
Right.
in another organization and prove you can do it twice, and that you can learn different clinical cultures and different clinical delivery systems. And so, yeah, I've had a variety of roles in organizations in Ontario, probably 4 hospital settings in the Ministry of Health. And I think what I've learned through that journey is that it takes a whole, as the saying takes, it takes a village to raise a system. And I'm proud to say, hopefully, that's what I've been able to learn. And hopefully, that's what I'm adapting here at St. Joe's. So, yeah, I've come full circle. And what's brought me back to St. Joseph's Healthcare Hamilton, really, when I wanted to be a president and CEO, I thought, what are the institutions that I would fit in with? And where do I agree with their culture and their history? And for me, a large academic health science center in an urban setting was attractive, like Hamilton. And it was founded by the Sisters of St. Joseph's. And so if you walk through the halls of my organization in any campus, you cannot miss our history.
No.
And so here were these 8 women, right? It wasn't men. It was 8 women who came to the shores of Lake Ontario, and they bought a house and they started a hospital.
That's so cool.
And so we need to honor those ladies. One of them, who has carried on, obviously it's been about 150 years, but There's actually a sister right now who's 97 and still volunteers in our organization. And so
Amazing.
I think learning from them that anyone and everyone should be taken care of. And we'll talk about that theme today. So no matter who you are, what walk of life you come from, what God you believe in, who you love, what skin color you have, you're welcome here at St. Joe's. And that's a part of our history. And that's what attracted me to take this role.
Wow, what a story, and what a roundabout kind of way to kind of be back at where you started. I think that's so amazing. And I mean, we should have a whole episode talking about the sisters on like another podcast, exactly, because that's quite the story in itself, right?
It is.
I love talking about women and the power of women. So that's definitely something I'd love to circle back to. And the values piece, right? The fact that there are values that St. Joe's has that align with your personal values, and the fact that it's so important to bring those to the forefront. Like you said, no matter where you come from, no matter what your background is, that you'll be cared for. And I think that brings us to the conversation we're going to have today, because we need to talk about nurses and talk about nurses needing to be cared for, because there was and there is still quite a problem in relation to workplace violence, particularly with nurses. So one of the things that I read about you is that you've shared that every single morning before you start, you read workplace safety incident reports across your hospital. Was there any specific report or story from a nurse or a particular breaking point in which you said, you know what, enough is enough? I think we need to do a major public campaign about workplace violence.
Yeah. So let's start with the profession that I employ the most is nurses.
Right.
So I'm not saying that the other professions, whether you're a doctor or an allied health professional or a corporate support worker, that you're not important. You're equally important.
Of course.
But the reality is the most prevalent daily interactions that you'll have as a patient is with a nurse.
Right.
And so I'll share the two nursing stories, and then I'll share a story of a non-nurse, like a patient food worker. So I had read an article about this increasing evidence that was coming in. And so I was preparing to take this role. And I was just like, let's think about what's going to go on in these organizations. And I started reading about this. And so there was an article in the New York Times that said in the United States this was happening. And there hadn't been a lot of Canadian attention to it. So I thought, well, I need to talk to my team about this. So I did. As soon as I came in, I said, I want to talk about worker safety. This is something that's happening. It can't just be happening south of the border. There's something happening worldwide. So can you send me all these incidents? And the first couple of days, sure, I'm seeing hitting, kicking, spitting, etc. But there were two in particular ones, one in dialysis, and I forget where the other one was. I think it was surgery. And that's an important note. One, it wasn't the emergency room, and it wasn't mental health and addictions. So that proved to me that it happens everywhere. This does not happen just in emergency rooms to nurses. This does not happen only in mental health and addictions. This happens everywhere. I've seen incidents in surgery, dialysis, complex continuing care, maternity. So this happens all the time, and it happens everywhere.
Right.
The one incident from dialysis was a nurse who wrote in her report, the patient lightly touched my breasts. So we're moving from kicking, spitting, yelling, derogatory slurs to actually touching. And, I'm a rather candid guy. The word lightly also caught my attention. Mm-hmm. There's a grading scale that lightly versus, in some significant pressure, like it actually showed to me that the person writing it had courage, A, to report, but B, was a bit ashamed of it too, right? Like I'm gonna actually lower the temperature on it because I said it was lightly. Like I didn't know that there was a scale, right? That was acceptable, number one. So that was one incident. And then the second incident, what I tell often is that I'm in Washington, D.C. visiting a friend. I've just left the African American Museum of History, and I open up my work phone, and a Black nurse is called the N-word. And it stopped me in my tracks. Here I am, literally just leaving this amazing museum about the history of African American culture and everything from slavery to salt trade to the great things about Obama and the ascension of that. And bam, it's 2023. And in my own organization, someone continues to be discriminated against based on race.
Right.
And so it was that moment that stopped us in our tracks and said, there's definitely hitting, kicking, spitting. and yelling, but I've got now a racial issue and I've got a touching issue. And that was important. And then the third one was, this is happening everywhere. And so it's a medicine inpatient unit. The food service worker walks into the room with a tray, knocks on the door, does exactly how they're trained, knocks on the door. Hi, patient A, I'm food services person. I'm coming in to serve your meal. Remember, what's left in the room? The former meal tray.
Right.
She opens up the door and the patient hits her with a meal tray. And so this happens to nurses, this happens to allied health professionals, and this happens to our frontline dietary staff.
Yeah.
And so it was those moments that said, it's our obligation as an employer, not to mention just human beings, that we have to do this work. And it's important work, and we have to take a long-term view of this. We're going to address it quickly and pay attention to it. But here we are almost 3 years later, and I think we've made some progress.
Yeah, I'm glad that you touched on the other forms of violence, because I think for the most part, when people think about healthcare violence, it's those various things like you mentioned, like the hitting, slapping, and of course those things are completely inexcusable. But the ones that we do hear less of are, the sexual touching, the inappropriate gestures or things that might be said to nurses as well. And as well as this racial violence. I myself endured racial violence. And it's one of those things that I think when I think about Canada, and again, going back to, you were reading a newspaper in the States and saying, oh, well, like, we just don't talk about it here. I think there's that kind of good Canadian, like, oh, we're so polite. I think there's this perception that we don't have those things here. And it's just like, okay, well, racism has no borders, violence has no borders. It's just we don't talk about them as much. And I think that is something that we need to work towards, where we have the courage to have these conversations. Because again, when I worked in quality improvement, we wanted to hear these things so we can actually do something about it, because we know that it's happening, but not reporting on it doesn't mean that that also means that you're not acting on it. So I'm glad that you mentioned those other forms of violence, because they do happen very often within nursing and within other professions, as you mentioned as well. So you started a very public campaign. I got to witness it myself. I took my mom to the ED, and I was actually pretty shocked to see these things, because you don't typically see this type of imagery, this type of wording. And so these public exhibits depicting, real violence that the staff face, and really sharing publicly that this is something that's unacceptable and something that happens and occurs on a daily basis. It's actually quite a bold move for a healthcare system. Tell me a little bit more about it.
Sure. I think building off of your comment, you have to act. And so the campaign that you're talking about is it's not okay in a cafeteria, and it's not, or a cafe, and it's not okay in a hospital. But that was just released. So we had to build to that, right? And so the first one we did was start to encourage reporting. And so at least on the racism ones and the sexual touching events, I would email the staff immediately. So I just don't read them. I email the staff.
Yeah.
I say, thank you for having the courage to report. Here are the resources that are available to you. I've copied in your team, as well as whether it could be the EDI team or the safety team, the HR support team, psychological team. We're here to help you, and thank you for reporting. And that started to gain traction. All of a sudden,
someone's listening.
The CEO and the chief nurse are writing me,
right?
And they're saying, we're behind you, and here's the supports. That's the first thing. The second thing is that we started to document this in patients' charts. So you're going to call my nurse the N-word? That's going in the chart.
As it should.
Right? Like, it's not in a separate file. It's in the clinical chart, right? And it's not like, as you know, Amie, that in some organizations, you're labeled a potential violence risk, and we call it a purple file, right? Well, we just don't say you're a purple file. We tell you why you're a purple file, and it's in your health record. So, when staff started to see that was happening, they were like, there's action here, right? And so go to your Canadian values. Sure, I've literally seen in the United States something that says, if you're going to act this way, we're kicking you out, right? We have different legal laws, we have different cultures, we have different norms. So I have to take care of you, right? But I also don't have to put up with this. So how do I manage it and find that nice spot between those two? And so have we asked families to leave? Yes, we've actually put trespass orders on families, because it's actually the family who's reacting and not the patient. And so You can't just run a campaign without actually showing some action to begin with, right? Because what happened is the staff came to us from the Joint Occupational Health and Safety, which ONA, as an example, would sit on, and said, you know, you have all these signs around this building that says you don't tolerate violence, but the fact of the matter is you do.
Yep.
Right? You do. And so the sign doesn't back up what you're trying to change. And so while we were starting not to tolerate it, they still were proving the points across our sector. Those signs are everywhere.
Right.
And so we changed that actually to it won't be ignored. Right. And so won't be ignored means we're going to address it. We're going to send security up if we need to. We're going to put it in the chart. We're going to manage these things. And then we're going to say everyone has to do no harm. This is a two-way street. So the first communication strategy was move away from toleration because it has no traction. It's lost its meaning to frontline staff.
I agree.
But every frontline staff, whether you're a nurse or a doctor or an allied health professional, has signed an oath that says, I will do no harm. Well, guess what, patient and family and client? You too should do no harm.
Yep.
So, and by the way, the literature is very clear. If we both don't do harm and we treat each other with respect, your outcomes are going to be better.
100%.
And so that was the first step. And then the second step is exactly what you've just described, which was launched in the last couple of months, which is it's not okay in a cafe and it's not okay in an emergency room. It's not okay on the road. It's not okay here. And we're also telling the story because, one, we've done a lot of work behind it here at St. Joe's we're very proud of. So our reporting is up almost 40%. And our harm, so lost time injuries, is down equally about 35%. We've also reduced lost time injuries. And so, because we've also started to train people, if you think there's a risk, you go in with two of you. Can I staff every bed with two nurses? No, I can't do that. Right. But if I have a high risk patient and you don't feel comfortable going into that room, unless it's life and limb, don't go into that room.
Right.
Right. And so go in together. Right. We've also started to change our infrastructure. So one of the other incidents that I'm recalling now, Amie, is and it was our fault, right? So the nurse is trained. It's a mental health patient. Fair enough. Says, patient, we're going to go into clinic room A. Nurse goes into the room first.
Right.
There's only one door.
Yep. It's a trap.
There's no window.
Yeah.
And the patient grabs her rear end.
Yeah.
Right?
Yep.
So now we're starting to think about, we can't necessarily have a door on every room, but maybe when we know there's a high risk situation in a clinic, we're going to build 2 or 3 clinic rooms with a window, with 2 doors, right?
Other ways out, yeah.
And start thinking about these things. And I think we needed to tell what we're doing, just not that it's a problem. Otherwise, it's just management speak, right? And so your listeners are going to sit there and go, it's just management speak. You know, hopefully, and you can talk to my frontline staff, they're going to say, reporting's up because he allows us to do so. He's dealing with this through an EDI lens. He's looking at supports for his staff. If I'm a part-time worker, I'm still going to help you because you were injured on the job. I'm not going to say you don't have the benefits, right? We're starting to put these in because we would like to say it's not just about the campaign. It's about what's behind the campaign, right? And so that's why we've done it. And I think it's important. It's, people come to work every day for a 12-hour shift. In their family's eyes, that's a 14-hour shift. It takes them an hour to get to work and an hour to get home. My number one job is to get them home.
Yeah. And I think that's how nurses feel. Like at the end of the day, we do want to go in and do a good job, but we also want to get home to our families. And I think that there's this perception out there, and I've seen it. I've seen it on social media. I've heard other people make these types of comments. Well, what did you expect? It's a part of the job. It is definitely not a part of the job. And I'm glad that, St. Joe is taking this one step further because, again, the accountability piece is there and also doing something. Because I'd say that for the most part, I think a lot of nurses would be like, this is lip service, right? Like, what exactly are the measures that are put in place? How are we measuring and how are we seeing that something is being changed? And it sounds like, that type of work is being put in at St. Joe's. What's the reception been like from nurses and staff?
Yeah, I think it's been positive. But listen, sometimes they only tell the boss the good news.
Yeah, I was going to say, let's talk about the pushback too. Any discomfort around.
But I think the response, if you look at our reporting, just 3 years ago, there were 979. I got the data in front of me now, 979 reports. It's up to 1414 this year. Like that's a 40+%. So if even just by the number one thing I could measure is, hey, this guy wants us to report, Brooke Cowell, their chief nurse, wants us to report, that's a positive sign. Number one.
Increase in trust.
Number two, we have them design this with us. And so when we did the do no harm and we did the it's not okay campaigns, those were St. Joe staff. This was not some AI generated campaign. We didn't hire a public relations firm to do this and find actors. This is our frontline staff saying, we're on side. We're going to do this.
Right.
And they've not been shy at saying, hey, listen, this is a concern here, and we tackle it. And so it's hard. Sometimes some of the stories we hear are difficult to hear. So I think pushback would be, and look, I respect Ona's position on this, what I'm about to say. We need more nurses. We need some technology to help us as well. And so we'll listen to that for sure. But I think between reporting, supports, addressing EDI as well, and not backing away from that. I'm a white man. I've met with 25 Black staff, and they've said this is the first time the leadership team, at least in the last 10 years, has met with us on safety of our staff who are Black. So, but again, I don't live in that world, right? I don't have that lived experience, but I think there's progress to be made here. And are we perfect? No, we're not perfect. I have seen some incidents that we continue to tolerate, or staff want to say it's okay. That happens. Well, it doesn't have to happen. And so, yeah, I think there'll be some who will criticize. There's still a little bit of, well, there's still a patient who does X, Y, or Z. I can't solve every problem overnight. I'm not trying to be not accountable for that, but I'm all ears and happy to listen to frontline staff on how to do this. And as we redesign our buildings in particular, frontline staff input into design will be critical.
Yeah, no, I think that's whenever something is being built, again, I like in Black communities, we say nothing about us without us, right? So it's just or even really in any community, you could say that, because I think it's so important that the people who are living this be a part of the design. And it won't work otherwise if they aren't a part of the design and don't feel that they have the space to truly, share themselves and to share their thoughts and opinions. And it sounds like you're creating that type of environment at St. Joe's where, you might have to hear those uncomfortable stories, but it's being actioned on. Something is actually being done about that. I kind of want to circle back to some of the pushback. Is there any other types of, for example, I remember posting about it and hearing some nurses, at other organizations just being like, well, why did it take so long, that people are starting to have this conversation? With this reality on display, has there been any other hospital organizations that say, that might be even using this as an example?
There's been some good work in the sector. I think, so I really don't know how to, if I'm not answering your question, please call it out. In 2015, the Ontario Hospital Association put a big summit together around on this, and they had a good framework actually at the time. But what we've added, and we've used their pillars, but what we've added to that is research and education. And so we're also researching our work. Physicians in particular, and I know I'm on the Gritty Nurse podcast, but physicians in particular don't report, right? And if you're an experienced nurse, sometimes you don't report, right? Because you don't know what you're training people. You need to be the calm, cool, collective one, and you're training someone. And so we've also noticed that, like, sometimes you would expect a 20-year nurse to report. Well, let's talk about the 20-year nurse, first of all. So one, she probably grew up in a culture where reporting wasn't encouraged.
Right.
Two, there wasn't a sudden change in society in the last year that we've had in across the globe economically, in the pushback unfairly against EDI. She probably didn't understand EDI at the time, depending on the nature of her background. And yet she's responsible for training the next generation of nurses. And I don't want to tell a negative about a job I love to the next generation of nurses.
Of course.
Right? And so I think if you were to talk to university presidents and faculties of, nursing, do you actually cover personal worker safety in your curriculum?
I think I know the answer to that.
To know your answer. Right. And so I think some of the pushback, you can't blame people for pushing back. There's been, then the pandemic happens. They're held as heroes. And then all of a sudden it changes, right?
Right.
Like
Huge
it
shift.
changes. And it changes for a variety of reasons, economic, socio-political issues, whatever. But it changes. And then all of a sudden somebody says, hold on here. Like, you know how many double shifts I did in pandemic? Do you know how many I did there? Like, do you know I trained as a nurse online? Like, do you know I had to do that? Like, do you know I had to go into a long-term care home, which was like, infectious disease, big problems. And then when I get back in here, I'm being kicked on, I'm being spit on, I'm being yelled at. So there's pushback just on like, are you even aware this is happening at the front line?
Right.
And then the second one is, are these actually tangible changes that you're making? So I think those are fair pushback. Do I have a lot of pushback now in my organization? Look, go talk to a frontline staff. I'm completely comfortable because you know what my answer will be? Great, let me talk to that frontline staff person.
Okay.
That'll be my answer.
All right.
Right.
Well,
and let's go fix it.
Now you challenge me to
you know what I mean? Like, go talk to them and say,
shows.
and look, and if we've missed. And I think that's the future of leadership in this area needs to say, hey, we got it wrong there.
Yep.
Right. And so you were in quality improvement, you said. So the best thing for quality improvement is to say we got it wrong.
But we don't hear that a lot, Mike. Right? That's the thing. This is why I feel like you're an anomaly in the system. You're a blip. You're part of the matrix because we don't hear that. Like healthcare just is one of those areas where we just don't hear the fact that we got it wrong. Yeah.
Well, I can tell you here, because my staff had the courage to come up and say, those signs of do not tolerate says this organization tolerates. You tolerate this. So, did we try? We tried. Sure, we tried. But it doesn't mean the outcome of that attempt was impactful. And so what's impactful? The other thing about quality that we've started to do, and we're not good at it yet, we've just started this, is when we have an adverse event clinically with a patient, well, you've been on the front line, you've been a director, a nurse, manager, et cetera. What's the first thing the quality department do? They call you and they say, we're going to review this case. Right. That sends a shiver through the organization. Right?
It certainly does. Yep.
Right. And we're going to talk to Dr. A, who's the MRP, and we're going to talk to the nurse manager. We're going to put you in a room and we're going to do a quality of care case
review. Yeah.
Right.
Yep.
And if you don't manage that from a just culture properly, that could go sideways. Right. And so we've only done 3 of them, we've started to review these incidents like that. So nurse A reports an incident and we say, I think that needs a review. And we look at the infrastructure. We look at what was the staffing on the unit that day. What was the patient? Who was the patient? Did we tolerate something from the patient? Was it the family? Right? And what can we do there? We've just started it. I think we've done 2 and we have to get better at documenting it and building a framework like the quality of care reviews. But I think that's also saying there's data and then there's like stories.
Right.
Right. And so, that's how we learn these type of things. And so, look, you're asking the guy who's the president to say, what are the negatives? I think no one's going to get anything perfect. We have readmission rates. We have return to ED in 7 days. We have a variety of things that move on clinically, and we're going to have some gaps when we try any management initiative like this. And so,
but at least
honest to God, if someone wants to say, talk to Amie and he's missed this, I'll be all ears and I'll do it in a respectful way.
All right. Sounds good. No, I'm actually encouraged to hear this conversation because I would say that there are very few leaders that I've spoken to that is open to saying that, we've got it wrong and this is how we're going to go around to try to change it. Right. So for me, that's kind of a win. Like I would want to work for an organization that has that transparency and has that accountability model where they're saying, okay, we're not going to get it right 100% of the time. Because again, I think that just shows the human side, right? Because humans make mistakes. And again, with my quality mind is just like, okay, so if we're making mistakes, how do we improve and make sure that we don't do this again? And it doesn't mean that the situation won't happen again. It's just like we might find a different way and a different approach to kind of figure this all out and that we're trying to do it together. Because that's the other piece. Like no one has it all figured out. And if any hospital out there says they have it all figured out, then we know they're lying. So at the end of the day, like I think it sounds to me like you're going down the right track. So I'm going to bring it back to some of these questions in relation to safer workplaces. So you mentioned that this is a two-way street. Nursing bullying. It's an ugly word, but it happens. So nurse to patient happens as well. What are the responses like in relation to these forms of workplace violence? Whether it's, like nurse to nurse, physician to nurse, how is that being handled at St. Joe's?
Yeah, it's a fair comment. So first of all, I haven't heard the phrasing of nurse bullying, so thank you for the introduction to
What?
that. It's
Oh
not been
dear.
presented to me. Like, I can only speak to what's been presented to me. So I think that's fair. Like, do we have nurses who are bullied? Yeah. It'd be
By
interesting.
other nurses?
What you've tweaked me to is it'd be interesting to now start to classify our data along those lines too, right? Just rather than just physical, it's actually bullying, right? So let me thank you for that piece of of conversation, and we'll take that back and see what we can do with it. Do we have some staff to staff concerns? Yeah, we all do. Sometimes there's heated arguments and things happen, and we manage those like anyone else. Like, no one comes to work thinking I'm gonna. At least I hope they don't. I'm gonna put someone in a psychological or physical harm's way, and I
Right.
think we would have all the standard work around that in terms of occupational health and safety, public policy, legislation, and regulation. But it's not been a focus of this type of work. This really has been, hey, first
External
step,
facing.
you're in front of the patient or the client.
Right.
In some worlds, that is the customer. And so we need to get that right. And I think if we get that right and we're all supporting there, we should decrease our internal.
I
right?
agree.
Because you now have two nurses who say, we're going to go on this together. And those two nurses become partners, right? Or the nursing and the dietary staff become partners. Because I have actually seen a nurse with the dietary one. It was a good example with the tray. The person who stepped in and said, this is not right, was a nurse.
Good. And that's how it should be.
Right? Who stepped in
Right.
and said, hold on here a second. This is an important employee. You may not think they're important. They're just delivering food. But you know how important your nutrition is to your recovery? Right? That's a nurse who tells that story. Right? That's a nurse who steps in and says that. And I think that's what we're finding now is even our reporting's going up, but even in the reporting, sometimes you're seeing someone else report it than the victim. And so I'm seeing more collegiality amongst our own staff. So would I have to go and look, Amie, and get the data on nurse to nurse, nurse to doctor, et cetera? Yeah, I'd have to do that. Do I think it's an issue here at St. Joe's? No, I don't. At least not as significant as the public to that. So yeah, I don't think so. And I'll just go back to your other question, if I might. I need to promote that we're not the only ones doing good work here. A lot of work being done in British Columbia on this. A lot of work. Provincial government set its direction. UHN's done a bit of work on this stuff in terms of their emergency rooms. They've done some research on it that's been published, which is great. Trillium's doing some work in this area as well. So again, I think, for us, though, we're a downtown urban hospital with a variety of patient complexity here. And we think there's a chance to elevate the story and impact the national conversation. But we're not the only ones doing this.
Well, it's okay to give yourself a pat on the back.
Yeah, that's our sisters, Catholics. Don't tell those. You don't brag.
That's hilarious. So you just touched on national, so which is great because that's kind of where I was going with the next part of the conversation. I think you've actually been quite vocal about advocating for federal legislation changes. And again, I'm a huge proponent of also things have to be done at the hospital, but also, if it comes to a point where it is deemed as assault, there should be changes. So I know there's Bill S-233. How is this fight being, taken beyond those hospital walls to address those root causes in the community? What does that look like maybe a year from now? And, what metrics will tell you that this effort has actually worked?
We were in Ottawa at the beginning of June, meeting with a variety of members of parliament, including the Justice Minister's parliamentary assistant. We met with the opposition critic for justice. And that's a good thing, right? We're talking about healthcare from a justice perspective.
Absolutely.
Right? This is not the Minister of Health only, right? This was an opposition member of parliament who proposed the original bill, C-321. We are one of the only countries in the world that doesn't have what's known as an aggravation factor to be considered in sentencing.
Don't you think that's weird? But anyways.
Yeah. Well, I think that goes to our culture, right? Like you looked at, less than 3 minutes ago, I said, we're not the only ones. We're humble. Sometimes we're so proud of our healthcare system. We don't want to talk about the challenges within it. And so we become humble. So the fact that we're, just doing this is not surprising. Right? But here we are, and give that opposition member credit. He's from BC. He's not inside government. And he puts this private members bill together. And he gets unanimous consent for this. But it dies on the order table because of the elections. And these things happen. There's bills that die on the order table. It's unfortunate they couldn't expedite it, right, because of this. But here we are. So what the law would do to describe to your staff is, if there's an assault on a healthcare worker and someone is found guilty of that and they go to sentencing, it would allow the judge to consider that aggravation factor that it was done on a healthcare worker. And so, again, I'm not a lawyer and I don't know the criminal code that well. But in essence, let's say someone was going to get 3 years for that. Well, then aggravation factor might make that 4 or 5. They'll decide inside the criminal code, right? Because it's a healthcare worker. Again, we are one of the only jurisdictions in the world that does not have this, right? In the United States, they have to do it by state. They have state justice systems. But there are places like Australia, that aggravation factor is up to 14 years in prison.
Sounds about right.
Assaulting a nurse, right? A doctor, an allied health professional, a porter, right? And so this bill would do that, right? It's passed second reading, which is good news. Again, unanimously. It's going to committee in the fall. We're hopeful to present there as an organization, just not an association, someone who can actually tell the operational story from an operational lens.
Right.
But it's not through yet. Just because it's through second reading doesn't mean it's through the entire area. There are some who believe that a current bill, I think it's C5, I can't remember the number, which has to do with bail reform, would cover that. But that's bail reform. Yeah. And so we would like it clearly spelled out that it's an aggravation factor tied to being a healthcare worker, right? And so we're hopeful that given we've had unanimous consent to date, that would happen. That's really, really important. How that gets measured, that's another question altogether, right? So we're already seeing some folks who are convicted of multiple crimes getting back on the street. Look, there were 3 Scottish guys who came to this country and they assaulted a restaurant worker and got 3.5 years. We're not talking about guns and gangs and underground. Our justice system needs to say, this poor Indian, he's from India. He immigrates to this country, runs a restaurant. 3 guys from Scotland come in, don't pay their bill, and they kill him, and they get 3.5 years.
Wild.
So imagine a nurse looking at that and saying, I dedicate myself to community service. I'm from India. My parents came here. They educated me. I went to this great university. I decided to give back to my community in this way. Sure, I get paid. Sure. But that doesn't mean that then I get assaulted and someone gets 3 months for that.
Yeah, that's wild.
So, will it solve the world's problems? No, it won't solve every problem. Will I still have someone come in here and call that black nurse the N-word? God, I hope not. But I can't solve every problem. But I think these incremental steps are important signals to nurses that you play a fundamental role in our society.
Yeah, and
who helps the doctor deliver a baby? A nurse. Who's going to take care of you in a hospice as you pass away? A nurse. That's what happens. Sure, do we have OTs and PTs, and they play fundamental roles in therapies. But the fact of the matter is they're actually not even a doctor necessarily at a hospice at the end of life. Because they don't know when you're going to die. But the nurse is going to be there. And so we have to put these systems in place, and we have to have laws that signal this is a great profession to get into. And we have to have the courage to have that conversation. And hopefully that's what we're doing here at St. Joe's.
I hope so. It sounds like I said, it sounds to me like you're on the right track. And I think that, when I think about tying all of these pieces together, there has to be actions within, one, we didn't talk about community, but again, there has to be stuff that's done in the community. There has to be things done internally within the hospital walls. There has to be some type of legislation, and there has to be, accountability behind all of these things. And I think that I really want nurses to also think, because sometimes this also happens where we feel that, the only system that we operate in is within the hospital system. And they don't even think about, human rights tribunals or other things outside that can help support them. And I think that, understanding that there are bills and legislation, these are things that nurses also should be mindful of to get behind, so they can also bring that momentum forward to bring about these changes. It's crazy to me to think about, like, police, firefighters, other, jobs that have, risk, danger associated. And for whatever reason, when we look at nursing, and I don't want to just say it's because it's a female dominated, I think it's a part of it, that the same protections aren't in place. I know people think twice before they decide to attack a police officer. And I think that I would love them to think twice before they assault a nurse. I don't know if you've seen this, but it's gone quite viral on social media. I don't know how much you are on social media, of a nurse who was trained in Brazilian Jiu-Jitsu, a sport that I took up as well, that actually was that a patient attacked them. And again, using these types of techniques, was able to subdue the patient safely and bring them down to the ground. Again, I don't think the onus should ever be on the nurse to have to do this, but it was definitely something I took up to keep myself safe. Because again, at the end of the day, I want to go home. To the nurses and healthcare workers listening right now, Mike, who are burnt out, who are hyper vigilant, feel like violence might be a part of the job, what is your direct message to them about their safety and their future at St. Joe's? Last words to you.
Yeah, let me add a couple of things if I could. I've talked today primarily from a hospital perspective, but we have nurses in long-term care homes. We have nurses in primary care clinics. We have nurses in home care. I've seen a sexual assault in a home. Not seen it, obviously. I've seen a report of it.
Right.
PSW goes in to a home. I don't know where that home is. 123 Main Street somewhere in Ontario. She goes in alone, and her hand is grabbed, and the man puts it on his reproductive parts in his home. There's a lack of reporting in long-term care because the key word in our legislation is home. That's their home, right? Well, we don't put up with domestic violence.
Right.
So why do we put up with violence for nurses and allied health professionals in a long-term care home?
Shouldn't.
So one, I will, say to the nurses who are listening or not from hospitals today, you matter too, right? And you need solutions that are unique to your environments. And so as an example, working with the technology company right now for that PSW and that nurse that does home care, because they're out in the field and they don't have a call button. They don't have a code white button, right?
Yep.
So we need to pay attention to that. And I have a large home care division. And thankfully, I have a lady of color who is a leader in this organization who convinced a frontline person of color and of a certain religious background to please report. Otherwise, I would have had no idea
that happened. Yeah.
That happened. And we're going to go fix it. So one, part of my last words is this is not hospital-based. This happens everywhere, right? Like 61% of nurses, this is Canadian data, at some point in their career will be assaulted, no matter where they are, right? And that's what we know because that's reportable data. But to your point, who think it's a part of the job, this is not a part of your job. So I'm the president and CEO of an academic health science center. I run a home care division. I run 3 long-term care homes. I run a hospice, and I run a hospital setting with a mental health and addictions focus. This is not a part of the job. This is not a part of the job of a construction worker to not be trained on how to use a ladder, or window washers that are not going to be safely equipped to do their job. And so if you're not safely equipped to do your job, you need to speak up. And if that's through someone like me, great. If that's someone through an owner representative or a union representative, great. But we just need to speak up. And then I need to know how to protect you. So one, I might have a solution, but again, I'm not in that unit, right? And so, we need your input too, which says, yeah, you might design your training like this, but I don't deal with that patient population. I deal with this patient population. And so what are the, tools, equipment, and training that you need to do that? And I think the one thing that drives me, my mind stops all the time, is when I walk into a unit and a nurse says to me, I can't find a blood pressure cuff. I can't find tape.
Where's the bladder scanner?
Right? So I'll also say every leader who goes onto a unit should ask two very simple questions. One, do you feel safe at work? And two, do you have the tools, equipment, and training to do your job? And so it does not have to be a part of the job. And if someone says it's to be a part of your job, like stjoes.ca has lots of openings. And we'd love to have you. And
where is it? Sign me up.
But look, if I were to talk to any other CEO in this province, and I've listed 2 other organizations today, I'll list a third. If you were to talk to Kevin Smith, the president of UHN, you would talk to Barb Collins at Humber River, you would talk to, Carly Farrow at Trillium. They would want to know too. And as would, a Roy Butler at St. Joe's London, Karen Davies at St. Thomas Elgin. The list can go on, and I don't mean to only not name a few. But there are leaders out there that want this changed. And I happen to be one who's a little more forward right now about it. But if there's a nurse out there that says, hey, I'm not comfortable here, if anyone says it's part of the job, I'll leave it this way. They're actually asking for patient care to be compromised. Right? There's a construction worker who goes onto site today, says, I don't feel safe today. You think they're building that home properly?
No. Yeah.
So the same thing has been said here. Dr. Chris Rabat, Christina Bowman, they've said, I go in and I'm nervous. I'm not going to be thinking right. Am I really doing that independent double check on a high risk med? Am I really checking the wound? Am I really cleaning that wound right? Have I ordered the right PT? So if anyone thinks it's a part of the job, they think negative patient outcomes is appropriate. Yeah. And that's not right.
And then I would say that the other piece is to ensure that, as an organization, the onus is on you to ensure that they feel trusted to share those stories and those moments with them. Because again, I think when I think about my colleagues who have suffered these types of, instances of violence, shame comes with it too, which is a wild thing to even think that, some of this might be their own fault. And sometimes they actually hear that type of language. So again, building that culture of openness, transparency, and accountability will make that nurse, wherever they are, whether it's a hospital, community, long-term care, feel that it's okay to say, you know what, I deserve much more, and here's why I'm going to share why this happened so we can make change together. And I encourage my nurses and other folks who are listening from the allied health world that it is definitely not a part of your job, and that we should be all speaking up together to make change. But again, Mike, I would say that the word, maybe the theme actually is courage here that you have within your organization to kind of take that first leap to say, you know what, violence is not acceptable here, and here we're going to talk about it quite openly. So I thank you and I applaud you for doing that as well, and all the work that you're doing at St. Joe's. I'm ready. Here's my resume. No.
Yeah. Send it in.
That's so funny. But yes, like you said, there's job openings, guys. Thank you so much, Mike, for coming on the Gritty Nurse podcast to share what's happening with your organization. Of course, you could let other CEOs know, feel free to come speak to me. I'm happy to have conversations right across Canada. But yes, thank you so much for coming on.
Thank you. You're doing important work, as is all your listeners. So thanks for having me today.
Thank you so much. Looking for a great gift for a nurse or someone who needs to learn about nursing? Check out my national best-selling book, The Wisdom of Nurses, Stories of Grit from the Bedside. Thank you so much for listening to The Gritty Nurse with Amie Archibald-Varley. If you're watching on YouTube or listening on Apple Podcasts, Spotify, iHeartRadio, or any other podcast platform, please hit the subscribe button so you'll never miss out on any awesome episodes from The Gritty Nurse. Thank you so much, and stay tuned until next time. Stay gritty.